Hi, folks. Good morning or good afternoon, wherever you are. I'm just going to give it another minute or so to let people into the webinar. Okay, it looks like people are starting to come in. Fantastic. Well, good morning or good afternoon, wherever you are in the country. I'm Bianca Frogner. I will be I'm just starting us off this morning. I'm the chair of the webinar committee of the award network. I'm joined by Maddie Sterling, who will be your MC for today. Today's presentation is about care models for aging veterans with dementia. Orna Intrator and Sam Edwards will be speaking. Orna is from the Finger Lakes VA Centers, or Canandaigua, as I learned, is how to pronounce that. And so that's in upstate New York, and Sam Edwards from the VA Portland healthcare system right down the street from where I am. And again, we do this monthly webinar series, and you can find out what our regular upcoming series are by scanning that QR code in the lower right-hand corner. You can also find all of our prior recorded webinars by scanning that QR code. And then we welcome ideas from you all because we want to hear from you about ideas that you want to see for future webinars. And that being said, our upcoming webinar is in early June with James Fletcher, who is the author of The Biopolitics of Dementia, a Neurocritical Perspective. And he'll be talking, his title will be, of his talk will be Making and Unmaking Dementia, a History and a Future. Just a couple housekeeping announcements before I hand things over to Maddie. Please save the date. We have our second Award Network annual meeting. It's going to be at the end of the annual research meeting of Academy Health, which is in Baltimore, Maryland this year. So it's in the afternoon, right after the Academy Health meeting ends. So and I know many of you are probably starting to schedule your time there in Baltimore. So please make a note of that and keep an eye out for more details. As always, I want to thank our wonderful webinar committee members who make these webinars happen every month. It's a lot of work, and we really rely on wonderful volunteers to really do and carry out a lot of this work. And Dr. Madeline Sterling, Maddie Sterling, will be the one hosting today. And so thank you so much for that effort. And before I turn it over to her, just a real quick mention of our leadership committee of the Award Network, including Joanne Spetz as the PI and director of the Award Network. And thank you to the National Institute on Aging for making this happen. I just wanted to provide that funding disclosure statement here for everyone to see. And with that, I'm going to pass it on to Dr. Maddie Sterling.
Thanks so much. Hi, everyone, and welcome. Today we'll be hearing about care models for aging veterans with dementia. We have two very exciting speakers. The first will be Dr. Orna Intrator, who's a professor of public health sciences at the University of Rochester, which at the Finger Lakes VA healthcare system. And she also directs the Geriatrics and Extended Care Data Analysis Center. She has a PhD in applied mathematics and computer sciences, and developed an extensive expertise in acquiring data, population-based data from CMS and from the VA. And in particular, her research has really focused on conducting comparative effectiveness studies to evaluate the impact of non-institutional care programs on cost, long-term care, institutionalization, and acute care use, which I imagine is very interesting to all of us. She's recently conducted studies comparing frailty measures and examining sources of algorithmic bias. She mentors several PhD students and has contributed to research on opioid use in VA nursing homes, continuity of care of veterans with dementia, and urban-rural differences in healthcare utilization for nursing home residents. The next speaker will be, so we're going to do this almost two speakers today and then a Q&A to follow. The next speaker will be Dr. Sam Edwards, and he is a primary care physician and general internist and health services researcher at the VA Portland healthcare system, and an assistant professor of medicine at OHSU. And his research focuses on the role and function of primary care with a focus on high risk, high need patients through home-based primary care, so HBPC. He has a Career Development Award from the VA, which uses mixed methods methodologies to examine what features of HBPC drive success at reducing healthcare utilization and outcomes. And he's been really doing some interesting work on sort of healthcare delivery change. He received his medical degree from the Cleveland Clinic, College of Medicine at Case Western, and did residency at Beth Israel Deaconess at Harvard, and also did a fellowship in general medicine and primary care at Harvard with a MPH from Harvard School of Public Health. So with that, I am going to get the slides up for our first speaker, Dr. Intertor. So let me share that. And then I will be advancing slides for her, but putting myself on mute.
Hi, can you hear me? I can't see myself, so I don't know whether the video is working.
Can hear you and see you.
You can hear me and see me. Okay, good. All right. So it's a pleasure to be here and to present to you a little bit about some of the care models for aging veterans with dementia that are available at the VA, and some of the work we've been doing regarding making sure that our veterans receive the best care, especially those, right now we're talking about the population with dementia. And thank you, Maddie, for the great introduction. I'm going to ask you to move to the next slide, please. So as a disclaimer, first of all, just to make sure we all understand that this presentation just presents my own views and does not present any views of the U.S. government or the Department of Veterans Affairs. Also, this presentation just summarizes several published studies, and I have a reference list, literature list at the end of the slide of the talk, and I would be happy to share that with anybody here. Next slide are just some acronyms, because in the VA, we're known to use a lot of acronyms, but I think just in general in medicine, a lot of acronyms are being used. I would imagine people will know current procedural terminology, CPT. F2F is face-to-face diagnoses. That's very important when identifying veterans with dementia or other comorbidities. FY stands for fiscal year. In the VA, we start a fiscal year in October, the prior year to September, the fiscal year. So this is fiscal year 24. It started in October 23 and will end in September of 24. GEC or GEC is the Office of Geriatrics and Extended Care. ICD refers to the International Classification of Disease. OMHSP is the Office of Mental Health and Suicide Prevention. VA is the Department of Veterans Affairs. VHA is the Veterans Health Administration, which is a component, probably the biggest component of the Department of Veterans Affairs. And VSSC is a tool that is provided and used in the VA, which provides a lot of summary information and summarizes some of the knowledge. It stands for VHA Support Service Center. So moving on to the next slide. Just a few words about what the Veterans Health Administration is. It provides care to approximately 6 to 7 million veterans per year. It's the largest direct care provider for homeless persons in the country. In fact, it is the largest single payer provider, maybe worldwide. Well, in the free world, but anyways, certainly in the United States. It's also one of the largest productive and most productive research organizations in the country, and it gets about $60 billion appropriated annually from the U.S. government to its services. It employs approximately 239,000 member staff, and it provides graduate medical education to over 110,000 trainees, including very many physician residents, medical students, and allied health trainees. So next slide. When we talk about geriatrics and extended care in the VA, we are talking about provision of services like home and community-based services, which include services such as homemaker and home health aid, skilled home health care, home-based primary care, which Sam will be talking much more about, veteran-directed care, adult day health care. Some of these are known, others are known in other names. Not going to talk too much about it, but there are a lot of different programs. It provides care in various residential settings and nursing homes. It provides palliative and hospice care, or it plans and pays for some of these services that help veterans and their families manage illness and plan care. Provides a lot of mental health care and health, fitness, rehabilitation. We'll move on to the next slide. So there is a conceptual organization of the GEC services, which we call the GEC Continuum of Vulnerability. It moves from more independence to greater dependence in services. So it starts in ambulatory care, goes, if you can skip to the next slide, it goes to geriatric and patient consulting, home and community-based services and facility-based care, and finally to end-of-life care. In fiscal year 18, GEC programs cared for over 287,000 veterans, of whom almost all, 243,000, received some community-based care, and about 80,000 received some institutional care, especially in nursing homes. So this is a broad population, and the services are either owned and operated by VA or purchased. This is a very needy population. So some estimates have said that the GEC office cares for about 6% of the veterans, but accounts for 32% of the annual cost, VAJ's annual costs. It's probably a little bit, it probably fluctuates, probably a little less than 32%, but it's still a big percent of all of the VA costs are spent on veterans receiving those services. Next slide, please. Now, going into dementia, what we term dementia, there's clearly, clinically, it is a very complex diagnosis. When we study dementia using data, we actually need to rely on whatever is available in the data, and that is based on diagnoses. But it's not only diagnoses. And so the VSSC, that service in the VA, defines dementia using various VA data sources. And it requires looking at only at encounters with qualifying providers, and requires combinations of 2 different episodes of care on different calendar days with a qualifying dementia diagnosis. Those qualifying dementia diagnoses were produced by the Dementia Steering Committee, and they're a set of ICD-10 codes. And the way they presented the VSSC in their documentation, they say it's any of the F02 codes, which is dementia and other disease classified, and other diseases classified elsewhere with or without behavioral disturbances, plus one of these other diagnoses. Now, it doesn't sound right to me, but that's what the documentation says. We have coded it, and so in the next slide, we can see that the VSSC identified 282,000 veterans with dementia in fiscal year 22. So that's the next slide, please. when we looked at that coding, looking at only a 2-year look back, if we used only VA data and we used the HCC, hierarchical clinical condition ICD diagnoses for dementia, we get 186,000 veterans, not 282,000. There's another system that's called the mental health clinical conditions, and that gets to about 170,000. And the Gen Frailty Index, ICD-10 diagnoses that relate to dementia, give about 257,000 veterans. If we add Medicare data, then those numbers jump to 240,000 based on the hierarchical clinical conditions, 322,000 based on Gen Frailty Index. So the numbers, as you can see, are very varied. They are around 200 to 300,000 veterans, but that's a big range. What we do see is that, and we had published this before, that when we add Medicare data, we get 25 to 29% higher number of veterans with dementia. So we really do need to rely on Medicare data, and it appears that it's possible. There's more Medicare use for pre-dementia or early dementia. That is a possibility, but we've never really studied that. The other issue is if we restrict our definition to only use face-to-face diagnoses, then we lose up to 30% of the veterans. So the issues are, and we can go to the, no, not yet, but the issues are that it depends on the look back period. There are problems in diagnoses, in diagnosing dementia. So some providers may diagnose dementia, but it's actually there are sleep problems or delirium, and so until there is a better blood biomarkers, these numbers are going to be very fluctuating as in any other place. But it does show there is a big population with a need for with dementia in the VA. Next slide. So the goals of treating patients with dementia are many-fold. We need to coordinate the care across systems, VA, Medicare, sometimes Medicaid, and it's essential in provision of veteran patient-centered care. Coordination of services can help lower the provision of duplicative services that can cause harm and unnecessary spending. Supports at home are for medical and social services provided at home. Those can support caregivers and allow veterans to age in place. And they also help in limiting transitions outside of the home to acute, post-acute, other settings, which are often confusing and anxiety-provoking for frail older veterans with dementia. Finally, but patients with dementia often exhibit troubled behavior that should be modified in order not to be harmful to themselves or to others. So we would like to support positive behaviors as it can manage stress, anxiety, and depression. And non-pharmaceutical methods are important in order to reduce medication burden and curtail the use of the deleterious psychotropic medications. So there are a lot of issues related to the treatment and care of patients with dementia, as you all probably are aware. And when talking about services to veterans in the VA with dementia, we're talking about inpatient care, clinic or outpatient care, telehealth, care to caregivers, which isn't often provided outside of VA. Respite care, for example, is exceedingly important in order to maintain patients with dementia in the community. And education to providers. These are all services that the VA does provide to its the veterans it takes care of. And it takes care of them by either providing them or arranging the care inside or outside the VA. And it's both the Office of Geriatric and Extended Care and the Mental Health and Suicide Prevention Office. So this figure that you're looking at right now presents the proportion of veterans who receiving any geriatric extended care services who used any non-institutional care in the left panel, any institutional care in the middle panel, and any hospice care in the right panel. And that's in 2010, 2015, and 2017. And then veterans with dementia are in green, and veterans without dementia are in purple. And the box plots are actually of the proportion of those veterans in a VA parent station, and there are 139 or 140 of those across the United States. As you can see, that varies across the United States by a lot. But you can also see that the veterans with dementia had a lower use of institutional services, of non-institutional services, and although those increased over the years, the veterans with dementia also were more likely to use any institutional services, although those decreased over the years. So we have been seeing in the VA in general this rebalancing, which is nice to see, but it could also be that we're seeing more veterans with lower needs coming in, and so the denominator may be changing in terms of needs. But in terms of hospice care, that has increased over those years, and it's actually increased much more after 2017. In 2019, there was a major change in the VA, but also lower use of hospice care among veterans with dementia. So there is certainly something to be thought about in terms of what they need and what care they are receiving. So next slide is actually I'm going to be talking about three different programs, a little bit about three different programs: the STAR VA Staff Training, VA Community Living Centers, which are the VA owned and operated nursing homes, continuity of primary care for veterans with dementia living in the community, and how that impacts, that makes a difference for care of and use. And then caring for older adults and caregivers at home program, which is a very particular program. All of these programs, the information that I'm presenting to you is from papers that we have written over the last few years, and these are just some of the programs that we've written about. So the STAR VA program in these community living centers, it's the STAR VA is the Staff Training and Assisted Living Residences, STAR. That's what it stands for. The intervention was originally developed for training direct care workers in assisted living residences to improve the care of older adults with dementia by successfully managing the challenging behaviors commonly exhibited by these residents. STAR VA adapted this intervention to be a veteran-centered interdisciplinary behavior approach for managing the behavioral symptoms of dementia in VA community living centers. Between 2013 and 2018, this intervention was implemented in 85 of 136 community living centers. A 2021 study that was published in 2021 looked at veterans receiving care by STAR VA trained clinician and used statistical methods to find matched controls of the veterans cared by clinicians who did not receive STAR VA training. And it showed a big difference in difference design in terms of the doses of antipsychotics received prior to STAR VA training to following STAR VA training. So the results indicate that those veterans treated by STAR VA trained staff had a reduction in their medication load of 55%, whereas controls didn't have any reduction. So this is very promising that there is a staff training that can assist in reducing antipsychotics used to manage behaviors. Again, there are currently a number of other programs that are being tested in the VA, Montessori kind of programs, music intervention, and so on. And I'm sure there are in the community as well. Behavior is a huge issue with dementia. Next slide is a little summary of the work done by one of my graduate PhD students, Leanne Lay, for her dissertation. She did her dissertation on using VA data on veterans with dementia living in the community. And she was testing whether greater continuity of primary care resulted in, among this population, resulted in a better health care. And she used an instrumental variable approach and showed that greater continuity of care was related to less hospitalizations, lower cost, and more successful hospital discharge back to the community. It's a series of 3 or 4 papers. She used the Weiss-Boxerman continuity of care, and when she compared the third quartile to the median, she saw big decreases per veteran per month, total VA, or maybe these are per year and not per month, total VA and Medicare costs in fiscal year 15, acute inpatient costs, emergency department costs, any nursing home care costs, community-based skilled home care and community-based personal care services were increased. So there is a cost to providing so they actually, these veterans receive more care that is needed for treating veterans with dementia, but then overall costs are actually reduced. And if we go to the next slide, we see that also in this much smaller program of caring for older adults and caregivers at home, the COACH program from Durham, VA, which showed that it was able to have a so it was associated with higher utilization of ED, hospital, and personal care services. So on the one hand, the personal care services like we saw before, but also ED and hospital, possibly for better diagnoses and of dementia and other conditions. There was a lower long-term institutionalization in nursing homes. So the COACH program enabled veterans to stay at home longer, but required more services at a higher cost. And this is kind of the toss-up that we are trying to identify. So, and some, I do want to say a few words about GECDAC, the Geriatric and Extended Care Data Analysis Center, which helped in conducting all of these studies. It curates data across systems, meaning not just VA, but also Medicare and Medicaid and other services. And it develops data linkages that help work with a broad range of data. And in that, I refer to the residential history file that we've created and assembles all of these different inputs and standardizes them, makes it much easier to work with and address questions of interest. It develops and produces the systematic population-based measures like the Gen Frailty Index and other frailty measures, and it shares these linked data and measures broadly across the VA. So we've developed sharing mechanisms. So anybody in the VA, any researcher in the VA with appropriate IRB or authority can get access to these data, which we continue to update. And so this helps progress make it possible to study and make progress with answering more questions about the care of veterans in these populations in a more timely and systematic manner, and using a common language, basically, or a common data source. And it develops the analytic workforce by providing training on the data and also its own workforce. So with the next slide, the discussion is with the growing tsunami of older veterans, many with dementia, we need appropriate services, tools to manage efficient and effective use. We need appropriate services. We also need tools to manage efficient and effective use of services. And we need comprehensive integrated data to do that. So efficient, effective care requires better targeting. Ultimately, the goal of treatment of patients with dementia is quality of life. So any care of patients with dementia must address caregiver needs. And finally, next steps that I see for us is to examine cost effectiveness of programs. This relates to what are program costs and are they optimal? What are important effectiveness measures? What are best targets to achieve efficiency and effective treatment? And we need to expand access to complete data from all providers and curate linkages. That has been an ongoing problem that we've been an ongoing fight that we've been fighting in the VA for many years. And Sam, I know some of this, but working between the two government offices, VA and DHS and CMS in particular, is pretty challenging. And so I'll stop there, and I think we can move on to Sam and then later on questions. So thank you for listening.
Terrific. Thank you so much. Dr. Edwards, if you're able to share screen and you can just go right into your talk next. We'll hold questions for the end.
Sorry, just trying to get all the pieces there. Can you see me and my slides?
Yes.
The right screen is sharing? Okay, great. Well, thanks for inviting me, and thanks, Orna, for introducing the VA and all the great programs we have going. I'm going to talk in a little more detail about a program within the VA known as home-based primary care, and specifically about patients with dementia who receive care in that program. So just to reiterate the slide that Orna already shared, so your geriatric extended care within the VA has a range of programs that can touch people with dementia. And just to highlight that home-based primary care falls into the home and community-based long-term services and supports program, which is among many other services it provides, including adult health care, veteran-directed care, medical foster care, skilled home care. So it's not inpatient, it's not ambulatory, it's sort of somewhere in the middle, but just represents a piece of the whole spectrum of the way we think about how to care for people with these sorts of needs. So the basics of VA home-based primary care, it's comprehensive longitudinal primary care delivered at home by an interdisciplinary team. So it's a big team. There's a primary care provider, which is either a physician, nurse practitioner, or physician assistant, nurse care managers, which really make up the main workforce of home-based primary care, a mental health specialist, so a psychologist or psychiatrist, a rehabilitation therapist, either a physical therapist or occupational therapist, pharmacist, clinical social worker, dietitian, and then sort of medical support assistant to help coordinate and do administrative work for the team. Practically, HPPC works as a referral service. So within the VA, any provider can refer to home-based primary care. So it could be an inpatient team, it could be a primary care team, a specialist, doesn't matter. Anyone who can place a consult. Typically, the teams do some sort of chart review and accept or decline the referral. Sometimes they might go meet the patient first, depends on a lot of things. Big reasons that are declined is patients live outside of the service area of the VA, of the home-based primary care team, since you have to physically travel there. It's, there's limitations. Then the next step would be a sort of a full in-home intake assessment. So a nurse goes to the home, they do a comprehensive functional assessment, evaluate the home environment, social support, as well as taking sort of a full medical history and exam. That nurse or provider will typically present that patient at the weekly team meeting that all home-based primary care teams have to kind of establish a care plan for that patient. At that meeting, they might decide sort of which members of the team are most critical to meet that patient at that time. It's very common for the social worker or a pharmacist or rehab therapist to make an initial assessment. And then things tend to settle out where the nurse sort of ends up being the primary care or the main provider of care with supervision from the provider. And then veterans receive an average of 2 to 3 visits a month. But as many care programs for extremely complex sick people go, this is highly skewed, right? So there's some people getting lots and lots of care, and then some people really quite stable, as I said. So it's primarily nursing visits, but sort of other team members as needed. And the goals of the program are to maximize independence and quality of life of veterans, minimize hospitalization and institutionalization, and sort of allow veterans to die at home if that's their wish. Sort of who HPPC patient targets is sort of for patients with complex chronic disabling disease when routine clinic care is not effective. So this is language from the VA policy. Classically, this idea that people are just too sick to go to clinic. So here's a range of definitions as outlined in VA policy documents. People who have high utilization of healthcare resources, so lots of recent admissions or emergency department visits, unscheduled clinic visits, missed appointments, anyone who's at high risk of hospital, nursing home, or recurrent emergency care, or nursing home placement. So an important distinction that we make is, what's home-based primary care and what's Medicare home health care, right? Because Medicare home health care, they'll send nursing staff and rehabilitation therapists and social workers into the home. But Medicare home health care really is, sort of targeting remedial conditions frequently after a period of acute care, like a hospitalization, while HPPC is really targeting people with complex chronic disease. Medicare home health care tends to be episodic and time limited and has sort of a fix and discharge mentality, while HPPC is really comprehensive primary care, sort of thinking of the Starfield's 4 C's of primary care: comprehensive, continuous, first contact, and coordinated. And then Medicare home healthcare has these specific requirements around who can get it, right? You have to have a skilled need. You have to be homebound. That's not true in home-based primary care. The teams have more flexibility about who they serve. And then fundamentally, Medicare home healthcare is really an adjunct to primary care or other physician or provider-based care. It is not the center of primary care the way HPPC is. So lots of great studies on HPPC that I tried to summarize here. So there's multiple studies that show that home-based primary care enrollment results in reductions in acute care usage. So 25% reduction in hospitalization, reductions in costs. So estimated about 11% reduction in VA plus Medicare costs versus sort of projected costs. I believe Dr. Intrator and her colleagues have some exciting new evidence in this space. So it's going to be coming up to the American Geriatric Society for those who are attending that. Also from Dr. Intrator, evidence that, patients in home-based primary care are less likely to die in the hospital or nursing home than sort of similar veterans or Medicare beneficiaries that are not in home-based primary care. So HPPC patients, 62% dying at home and 11.4% in inpatient hospice. So I'm thinking about sort of what's the secret sauce of the care model. I mean, people talk a lot in home care medicine about the idea of eyes in the home. There's just a sort of like instant synthesis and realization of like the patient's needs and why they're having so much trouble navigating the healthcare system when you walk into their home, meet their family, and understand their environment. The care that HPPC provides is fundamentally highly flexible, adaptive, and patient-centered, right? It's all about understanding the patient's needs and meeting them where they're at. There's a lot of attention to sort of non-medical needs and filling instrumental gaps in care, even if that's not necessarily an explicit goal of the program. And then this idea of dedication to the mission. So there's this really strong sense of mission and a really strong culture among HPPC teams about keeping veterans at home and maintaining their independence. So that culture is kind of hard to capture, but it's a big part of what makes the program work. Strong relationships and communications with patients and caregivers, so really strong partnerships, but in many cases, patients have limited social support and HPPC kind of serves as their caregivers. And then the multitude of coordination work teams do with specialists and outside agencies. HPPC is growing. So in 2003, about 9,000 veterans in 70 medical centers. In 2021, about 60,000 veterans in 140 medical centers with 300 satellite sites. And then GEC continues to expand HPPC by 75 sites. As Dr. Intrador noted, we have this demographic increase in older adults and the sort of need for more non-institutional long-term care. So just some quick data. This is all based on the GECDAC's amazing data resources, which Orna described. So this is a cohort of new home-based primary care enrollees from fiscal 15 through 17. I think it's actually they just enrolled in 1 year, but the data to get all the comorbidities straddles a couple years. But this pulls in data from VA, inpatient, outpatient, Medicare, the minimum data set, and Medicaid. So really comprehensive look. Of the 12,000 people, average HPPC patients are 77 years old, and 40% have the diagnosis of dementia. And this is using HCC codes, again, getting at some of Orta's work on how different definitions and administrative data. Looking a little closer at HPPC patients with dementia, so they're a little older, average age of 80, 2.7% female. So this is pretty typical for the VA HPPC cohort and the demographics of that age range in VA, although obviously that's going to change. About 80% white, 15% Black, smaller proportions, other races and ethnicities that may just reflect sort of not great race and ethnicity data within the VA. I put up a few medical conditions here just to give a sense. So these are, again, all patients with dementia, but you got 22% cancer, 45% diabetes, 30% heart failure, 33% pulmonary disease, and then almost half have depression and anxiety. Really just trying to get it. This isn't just any group of patients with dementia. This is like a highly multi-morbid, high needs group of dementia patients that are sort of getting care through this program. So some more data on patients. So risk scores. So the VA calculates a probability of hospitalization or death within a year called the CAN score based on prior diagnoses and utilization. So about 27% chance of hospitalization or death within a year. We calculate Medicare hierarchical condition category scores. So an HCC score of 1 is an average predicted cost for the next year. So you can see about 40% of HPPC patients have an HCC score of over 3. The mean is over 3, so that's high. Gen Frailty Index, another measure of frailty that predicts the need for long-term services and support. So 30% in the highest category of above 9. And then the NOSOS is a VA adapted HCC score, which again it indexes the predicted cost of a veteran versus the average veteran. And so this is this is very high, with an average 70% of HPPC patients have a NOSOS of over 3. Functional limitations, so 57% require assistance with mobility, 15% are homebound, 64% have deficiencies in 2 or more activities of daily living, and then 65% require assistance with adaptive tasks. So again, just like a highly needy group with a lot of functional limitations. This reports that only about 9% have no caregiver, but almost 40% of the patients have the caregiver has their own medical limitations. So we see this a lot with aging couples. 20% live alone. It's a little confusing with the no caregiver number, but we have to dig into that. And then about 25% based on their zip code of residence live in a highly deprived area, which is about sort of average for the population. This is a slide I've used in the past. It's not dementia specific, but it's kind of how I think about sort of the types of conditions and how they interact to lead to the need for home-based primary care. So these sort of buckets of having multiple chronic medical conditions, often a dominant disabling condition that kind of drives a lot of care, that leads to functional limitations, coincident mental health conditions, sort of inadequate social support, and then deficiencies in basic needs. And we see this a lot in home-based primary care patients. So just a few examples. So a 68-year-old male with COPD living in a supportive sort of Section 8 housing for older people, who has a spouse with stage 4 lung cancer, who's on 5 liters of oxygen, sort of deeply depressed, won't accept any care, and won't leave his house. So that's sort of, seeing how basic needs deficiencies and caregivers responsibilities interact to need home care. Here's a 52-year-old male with a stroke who's aphasic, hemiplegic, near total care. He had a stay-at-home spouse who now needs to work to support the family. So this is leading to sort of strained relations with patients and children, and also starting to impact their finances. Here's a 59-year-old with schizoaffective disorder who's on long-acting antipsychotics and just is scared to come to the medical center, has no caregiver or family, lives in a group home, and the HPPC nurse is the only VA staff that they trust. And then 72-year-old male with diabetes, end-stage Parkinson's, who lives in an assisted living facility, who can't really speak consistently or eat, and needs insulin. And then finally, a dementia patient example. So this is a 92-year-old male with severe dementia who lives alone, who has 2 sons nearby, but they're not really engaged or doing anything, and he's starting to exhibit dangerous behaviors. So HPPC steps in to really connect the care gaps to try to keep him safe at home as long as possible. Some outcome data. So this is just pre-post, no fancy analysis. So hospitalization rates go down after people enroll in home-based primary care from about 40% in the 6 months before enrollment to 27% in the 6 months after. Same with emergency department use. So this is emergency department visits without hospitalization. Decrease in Medicare home health care use, decrease in nursing home admission. Not a lot of changes in the other use of VA care. So the number of specialty visits stay about the same. These are just some graphics we've made of kind of cite where people are living and receiving care over time. So the yellow bars represent community. So this is sort of like prior to being in home-based primary care. 0 represents their admission to home-based primary care. And then we're looking at this at 90-day intervals over time. So you can see them move either between home-based primary care, nursing home settings, being discharged back to the community, or death. You can see at 720 days, we're seeing this is a random sample of 300 patients with dementia. So about a third have died by 720 days. You can see there's a lot of transition back and forth. Sort of trajectories of care, when this is based on interviews with staff. We see sometimes people get better and go back to clinic-based primary care, although this is kind of often discussed sort of with laughter. This is a very rare situation. This is a population that tends not to bounce back. But when this does happen, it's often because of increased social support, sort of a family member coming back into the picture. A lot of patients still get hospitalized. There's kind of an understanding this is just reality with this group. Sometimes people get discharged from home-based primary care because they can't make any impact. They're just not getting anywhere. Often this is sort of family members or patients can't engage. Obviously, patients die a lot in this program given their age and multimorbidity. So a lot of work on goals of care discussion, engaging hospice. Home-based primary care tries to stay engaged to provide longitudinal primary care, even if they get hospice before death. And then sort of a higher level of care, so nursing homes. So managing the transition to a higher level of care is a really common function of HPPC social workers and teams. And this is not seen as a failure or like the program's not working, but there's just a point at which home-based care is no longer feasible. And there's a lot of really nuanced work around running family meetings that are in the home. So this is sort of like things you might do in the hospital, but instead it's happening at home to help people get to institutional care in a sort of safe path. And then just kind of hanging on, wait until something changes. So as a primary care doctor, this is very familiar, and then this sort of tension about how people don't get discharged because we think HPPC is really critical to their stability. And if they get discharged, things are going to fall apart and there's no other primary care system that will work. But then there's also some recognition that sometimes people get too close. Nice patients don't get discharged. and that maybe we need to focus the program on people with higher needs. And I know Orna's done a lot of work on helping programs focus on those populations. So this is just sort of a pretty picture to show the sort of diversity of trajectories. So this is 300 patients, and each line represents their individual course. So the yellow section prior to the hard line at 0 is prior to admission to home-based primary care. So you can see a lot of people are having a mix of different kinds of care. So the color coding there shows community, Medicare, home health care, home-based primary care, home-based primary care plus Medicare home health care or hospice, institutional hospice, nursing home, emergency department, hospitalization, and death. So a lot of different states, but the general idea is that there's a range of sort of need for acute care prior to enrollment, and then a real big range of outcomes that can be pretty messy, right? A number of people still end up in nursing homes. We see this, about a third of patients die at 720 days, with sort of a lot high variation in course. One last picture. So this is people who die who were enrolled at 180 days prior to admission, or they were in HPPC 180 days prior to death. And this just is mainly to illustrate kind of something Orna has already shown, that most people who are in HPPC at 180 days prior to death don't die in institutions, and most of them get engaged with hospice before death. So we see 62% have engagement with hospice before death, and then almost 75% of patients don't die in institutional care. We see that the average days at home, which is the measure of the number of days within these 180 days that are spent not in institutions, is a mean of 150, which is really quite good compared to Medicare beneficiaries or VA patients that are not in home-based primary care, which is particularly remarkable considering what a sick group this is. So this is just a quote from a program director, sort of how they think about success in this program. So success looks different to us. Sometimes the success of the veteran in our classic medical model, we don't see the success. We have a lot of conversations about are we enabling a situation that's pretty marginal, and if we weren't going in, they would fail. Sometimes it doesn't matter how marginal it is. If the veteran's at home, he's successful in it. So I think that kind of captures that sense of mission among HPP provider, BC providers. So anyway, to summarize, I know it's a lot. About 40% of patients in home-based primary care have dementia, and these patients have really complex combinations of multimorbidity, functional limitations, deficits in basic needs and social support that put them at high risk of hospitalization and institutionalization. Eyes at home, sort of flexible care, strong culture, partnership with patients and caregivers are key drivers of success. And that, we see really complex and variable care trajectories, but on average, we see reductions in acute care use, common engagement with hospice, and spending a large majority of time and dying outside of institutional care. All right, I'll finish up and hopefully we have time for a few questions. Thanks for listening.
Thank you so much. Lots and lots of content. I see 2 questions in the chat. I think both were about the prior talk. So maybe Dr. Edwards, maybe stop share screen. We could just do Hollywood Squares. And the first question is from I just am having trouble pronouncing it, but I think Janine Ferrari. And I think the question was for Dr. Intrator. Are you working with veterans living in VA nursing homes too?
Well, yes, with the data of those veterans. So there's the CLCs conduct the minimum data set, just like all nursing homes in the United States. And they're also monitored within the VA, so with the same kind of quality measures and star rating as outside of the VA. But it's all internal to help promote quality of care. But the CLCs are very different, both in terms of the patient population and in terms of their staffing. The staffing is way, way larger than it is outside, and it's also hospital-based staff. So it's they're much more like hospitals. They're more like hospital-based nursing homes. Um, and their cost is more like swing bed nursing home facilities. So it's not prospective payment. And so it's really difficult to compare. But there is a paper that I published a couple of years ago that compares the veterans receiving care in CLCs to other locations. And that's pretty useful.
Great, thank you. There's another question about nursing home. I'm actually gonna switch because we only have 2 minutes left. From Dr. Xu, thank you for your talk, Orna. In the STAR VA program, do you look at behavioral outcomes after the intervention? Also, do you think the intervention could be applied to community nursing homes? So I guess outside of the VA.
Yeah, so we're just starting. There's a new resource in the VA that helps identify incidents of behavior incidents. So we're starting to work with it and have published one paper and are writing another paper and are working on using it more. So certainly it could be used to looking at the impact of STAR VA. I think there is some information about, I'm not sure that there's information about who in a CLC is exposed to the STAR VA program, or it's just like whether the CLC had training. Regarding what was the other question? What was the other question? One was about STAR VA.
The other question was about, whether the program, the intervention could be applied to settings outside the VA.
Oh, yes. Yeah. So yes, it can. And it actually started not in VA, but then was applied in more in non-VA. But then in Vision 23, which is up northern Midwest, Iowa, Minnesota, they started a program called the Behavioral Resource BRO program, Behavioral Resource something, where CLC STAR VA providers were helping nursing homes in the community manage the behavior problems of veterans. I don't know if they ended up publishing on it. They did do some evaluations of it. And certainly it's a good place to continue to expand the STAR VA program to nursing homes outside of the VA. But I also mentioned the Montessori approach, which is kind of underneath all of this. And I think this is underneath all of this kind of conceptualization. So I would suggest to look there.
Well, I really appreciate Maddie, your emceeing here, and Orna and Sam, you two as presenters today. We're hitting here at the top of the hour, so I know we're going to have to close things out. Maddie, any last words before I close this out?
I'll just say, I think you both provided such a helpful and comprehensive overview, both of data, of clinical services, of sort of the research in this space. And I know, Dr. Edwards, we didn't get to questions on your work, but just a comment is that I thought your slide with the clinical trajectories and examples was incredibly helpful to almost bring to life sort of the phenotypes of who we might expect to receive care. And, I could really picture kind of those flavors of patients coming. And also the slide where you had the pain points, I think was also helpful. So thank you both. And I believe this lecture will be
I think that is published. I think, Sam, that's published, your trajectories, right? We published the paper on it.
We published the whole cohort in JAGS, but I actually had them put together some dementia specific ones, but they're pretty similar.
Great work.
Yeah,
It's
you
it's
gave us
great.
so much information of what's such a complex system. So thank you for breaking it down. Well, thank you again to everyone who joined today. And again, this is recorded, so hopefully we can share this out to a wider group of people. So thank you again, everybody. Have a wonderful day.